We on? Can we hear me? I'm actually part of the pilot and pivotal studies for Infuse. So, I mean, I don't say that it's a get out of jail free card, but I mean, we're part of an FDA trial on it. So,
have they retracted the letter?
not to my knowledge. Again, I don't know. So.
I might just comment on that briefly with regard to legal implications. I've been involved in the defense of many surgeons who've used BMP, and it's a physician-directed use, and we could talk about that more, but I think in general, appropriate discussion with the patient preoperatively, documentation of that discussion, and the so-called off-label use. The FDA doesn't regulate physician behavior, so there's really not a big problem with the physician choosing to use BMP, even in non-FDA approved applications. I was going to ask you a question. Todd, I thought that was a terrific talk on new surfaces and new technologies, and you covered quite a few of the ones out there. So I'm left with wondering, what I'm really looking for is maybe a comparison between our HAP composite versus our nanoporous titanium versus 3D printed titanium versus perhaps PEEK alone or allograft alone. And that seems to be kind of lacking in the literature. So what do you think is the best, maybe a preclinical model that we ought to be looking at to say which of these materials really integrates best into bone and might be most appropriate for an interbody implant?
Well, I think it would be the preclinical model. To be honest with you, I don't know if I have an intelligent answer to give you on this, except doing a comparative analysis without graft on a preclinical model would, honestly, I think it'd be a sheep model. And the cervical was still not a bad one to my understanding. The lumbar is not as great in the sheep, but as far as a side-to-side trial, I mean, the biggest thing is seeing how these materials actually incorporate with the bone interface. Because we argue the fact that you're looking for fusion, but I would also state that what you're really looking at is what is going on at the cellular level. So how are these cages incorporating? And that's really what you're wanting to show. Because once you get bone growth started, bone is going to continue to grow. So I think that basically just having a head-to-head an analysis between each one of the cages and the same models you're using to validate it in the first place. So you validate your cage to show that it works, but when you want to do a comparative study, I think you have to set up a model where apples are apples. Is that?
Yeah, so I'm kind of setting this up a little bit to suggest that there really isn't a great head-to-head comparison. We could look at a metaphyseal pull-out model with dowels, or we could look at a calvario model, or we could look at a sheep cervical spine, as you suggested. We really don't have a lot of data to support one being better than another. Having said that, maybe I'll transition this a little bit to Billy for your talk on value then. There's a dramatic difference in the prices that we're paying on these, right? So, for example, in my hospital, nanoporous titanium is twice as expensive as HAP. So how is it that we're seeing these dramatic differences in prices in the absence of clear evidence of a difference in performance?
Well, I think that just highlights the debate overall, right? I mean, if you could effectively show that there's an increase in fusion rate with a fancy cage, then ultimately at the end of the day, if you do the math to look at the cost, not only for direct costs for hospital bills for patients who require revision, but also try to include in that calculation the lost revenue, the pain and suffering, then there may still be an advantage to the more expensive implant. The other thing is that we're surgeons, right? We're stakeholders too, and in looking at expandable cages, one of the things if an implant is easy to put in, if it is less stressful for you as a surgeon, then there's value in that too.
I agree. At least in our system, our hospitals are reimbursed based on DRG. And so they want us to be as cost effective as possible. With that said, I don't know if the hospitals are necessarily so worried about if a revision is required after the 90-day period, because then they get another DRG for that. So we have to be very careful. I mean, we have to partner with our hospitals, but we also have to do what's best for our patients.
Absolutely.
Great, thank you. We're good? So this is we have about 15 minutes before the next discussion on deformity. So this is, actually I just saw this guy last week, and the reason why I brought him up is this is now the new, becoming almost the new norm of my spine practice. So this is a 90-year-old gentleman. I don't remember seeing 90-year-olds 20 years ago very frequently, but now I see them all the time. And this is a very active 90-year-old guy, still driving, still married. He's been married for 60 years, and he's got this classic kind of neurogenic claudication that he's been dealing with for many years, but now he's to the point where he's only able to walk about 100 yards, can only stand for 10 minutes. He's been treated with probably 20 injections over the years, appropriately, facet joint injections, epidural injections, PT, and essentially he's a pretty healthy guy. Even his internist said, you know, if this gentleman needs surgery, he will likely live another 10 years, but he doesn't want to live 10 years the way he is now. So when we examine him, we also find that he is developing weakness, which he did not have before. So all of a sudden now he's at risk for falls because he's weak in his tibant as well as his quadriceps, particularly his quadriceps. That weakness, as you know, is quite debilitating. And you can see this is a typical spondylitic spine. He's got a spondylolisthesis at 4 or 5, which is quite evident, and then just a degenerative spine. If we look at these, this is the L4-5 level. You can see he's got quite severe spinal stenosis at that level, central subarticular foraminal. He's got synovitis of his facet joints. Trust me, he moves a couple millimeters on flexion extension, but his other levels don't look good. At L1-2, you can see severe stenosis. At L2-3, not as bad. L3-4, considerable subarticular stenosis, foraminal stenosis at all those levels. So now the question really becomes, what do we do for this gentleman? Who in the room would absolutely not operate on him based on his age? Because he's a pretty healthy guy. I mean, he kind of looks like an octogenarian. So Bill, what are you thinking? What can you do for this guy? As less invasive as possible, because as we know, the more you do, the more risk this gentleman has.
Sure, why don't you go back a slide? Could you? How about 2 slides? Or whatever shows the sagittal, that is. So at the end of the day, you know, I don't think there's much debate about if he has an intervention, a decompressive procedure is probably the one that makes the most sense. In terms of what to do about fusing segments, this may be a little bit off the wall, but you know, I've had this happen more and more where I've decompressed the patient more comprehensively than I've fused them, and so to me, I would decompress him from sacrum 5, 4, 3, 2, 1, from 1 to 1 or 1 to 5, and at 4-5, I would either do an in situ or I would do an instrumented fusion at 4-5.
So tell me how you would do an in situ fusion.
Burr his TPs and take some of the bone that I took to do his laminectomy and stuff it to the side. And what would dictate whether I would instrument him is honestly how sloppy he seemed in the operating room. I mean, if he seemed like he had a substantial amount of and there's other ways we can try to assess his spondylolisthesis if he's mobile on his flexion extension X-rays. But you know, at my institution, I have to. I mean, if I do a laminectomy on somebody and I'm worried I'm going to have my resident or fellow or maybe me, you know, bugger their facet up too bad that I want to potentially fuse them, I have to have informed consent for that. So to me, I would keep that in my list of tools at the time. But if you seem like you had a stable spondy on flexion extension and interoperatively, maybe do nothing, maybe do an in situ. I know it's a nebulous answer, but what do you really burn to do an in situ at 4-5 on a 90-year-old? Really nothing.
Correct.
Right?
Jason, did you have something to add?
Jonathan. One of the salient complaints was also right buttock pain, not just neurogenic claudication. And so I'd like to see the foramen probably at L4 or 5 to see if foraminal stenosis is a big issue. And it does look like it is. So, you know, obviously the L2 to 4 or L1 to 4 decompression makes a lot of sense. And, you know, that could be done open or minimally invasively depending on how expeditious you can be with the MIS technique. it doesn't look like he's terribly unstable at L4 or 5. It doesn't. There's not a huge fluid in the facet joints, and it's not like you're going to need a durable result here for 15, 20 years. But I'd be concerned about the foramen there. So and so the nerve root signature for the radiculopathy would be very important here, whether it's the lateral recess stenosis and more of an L5 nerve root signature or more of an L4, and that L4 certainly also can contribute to the quad weakness. So, as much as you'd like to do less for this patient, you want to make sure that you can decompress that exiting L4 nerve root, which may mean an interbody or may mean a little bit more surgery if the patient can tolerate it.
Yeah, to me, I'm not really that impressed with the 2-3 or 3-4, and that 2-3 parasagittal image that we had was it looked on the sagittal that it was maybe a little stenotic, but that was pretty right-sided. I think that most of his symptoms are coming from the 4-5 severe stenosis, and I would focus at 4-5 and not address anywhere from L1 to L4 and just go L4-5. And I think that as bad as the foraminal stenosis is, and he does have reasonable facet effusions there, I think he probably needs to be jacked up a little bit and have interbodies placed at 4-5. And you can do that in a relatively minimally invasive manner, especially as skinny as he is. So I would do bilateral facetectomies personally and make sure that his foramina were appropriately decompressed in addition to the lateral recesses. And I would do a bilateral PLIF on him and focus just on 4-5.
Todd?
I think, at least when I'm seeing more of these just like you, and every level always looks bad. And I think trying to ferret out where your patient's symptoms are coming from. And one thing I try to quantify too is, qualify is the pain truly neurogenic? If they don't have pain in the legs when they're sitting down or back, I'm not really worried. I mean, the back, I'm not really worried about it. And I think in this area, even at 4-5, he's got a significant amount of collapse. And if, again, you said trust you on the flexion extension, he does move some, but
couple millimeters.
That's not really significant. And so it's only been my practice is to really just do the minimal decompression. I don't do a whole lot of MIS. I'll still do an open limb by midline, but I still do minimal foraminotomies. And, as my adage is, he doesn't need to be wide open. He just needs more than he has now. And I think that you could do a multi-level, but I agree. I think there's probably only 2 levels that are symptomatic, and that's what you would address in this. But the other thing that I've looked at as the patients get older and it's deviating away from the spine, it's part of the decision-making risk and whose quality is improved at the end. And in some of the older patients, I really also stress to look at their cognitive impairments, if they have them, because the number one predictor for post-anesthetic cognitive decline is preoperative cognitive impairment. And it's hard for you to, if you're practicing like mine, you're going through 30, 40 patients a day, you're having a quick encounter with them, and you might not pick up the subtleties of things of this nature. So I don't trivialize it. So as the older they get, I do start looking for issues with cognitive impairment with them, because if any of you guys have had it, I've had 1 or 2 patients that you've done them on, they're older, and they were clearly much worse post-operative, and the family's upset, everybody's, and now they're forced to spend more time taking care of Pop, who can't now get out of the house anymore.
And that's a hot topic in the anesthesia. Can you do less anesthetic for this guy? Can you do it under non-general anesthetic? I've done cases under spinals. This is probably biting off a lot for a spinal anesthetic. But any of us that have been in practice for a while know, there's some very angry family members that come back and say, you've created dementia in my family member because of the general anesthetic. So it's a hot topic.
I have a question. So, 9 years old, at what point, especially if you're going to do an instrument infusion, maybe a little bit in the body, at what point do you want to take a look at his bone quality? And do you guys do that? And if so, is there a cutoff? At what age? How do you think?
So SIG would do it on any patient he fuses. This guy would get a bone density. And how about if it was so bad that you want to put him on Forteo for another year? Because this is an elective surgery, correct?
If you get an elective...
yeah, this is elective, but he's 90, so you're going to...
Anybody who's had a fracture, any woman over age 60, and any man over age 70, even if they haven't had a fracture, manufacturer get a bone density study if we do electric fusion.
So is there a hard stop on whether you would instrument him, or would you do kind of like what Bill was thinking about, and that is an in situ fusion without instrumentation if he's parodic?
I was more going to ask you a question, but I don't really get the whole notion of an in situ fusion, to be honest with you. And I know it's somewhat popular, but to me, golly, if I can get out on the transfer processes and if I can take down part of the facet joint, then it doesn't cost me anything to put screws in there. There's a financial cost to it, but it doesn't really add that much to the exposure. So in general, the reason I would fuse somebody is if they were unstable or if I really needed to do a realignment. And if I were going to do that, I'd almost always put instrumentation in there. Having said that, yeah, in general, somebody who's got a DEXA score less than -2.5, unless it's an emergent surgery, progressive neurologic deficit, I'm not going to do a multi-level fusion with instrumentation on them. They're just too high of a failure risk.
So I'll bite
So,
on that.
so you've had a long.
I'll bite on that.
You've had a long history of multi-level fusions. Do you have the same experience with breakdown, adjacent level breakdown, or some sort of osteoporotic issue with long fusions versus short fusions? Because 4.5 or 4.5.5.1, I just haven't had a lot of people breaking down or having issues from osteoporosis for short fusions.
Yeah, I'd agree with that, like 1 or 2 level. That's why I was saying multi-level fusion I would consider. I wouldn't do without a DEXA, but for 1 or 2 levels, I'm not that concerned about it, actually. I think that bone density is probably not that big of a deal there. There's not that much stress on the instrumentation.
Right.
And I usually use HA-coated screws, and they integrate quick enough that it just didn't seem to be an issue.
We're my thinking, and I was going to ask, how does the panel think about the presence of weakness? Because he's got quad weakness, and if this were just pain, I'd be very enthusiastic about decompression. My approach is to be very different for someone who just had pain. But when you see he's got quad weakness, he's got his leg giving way, there's a chance that even with the best decompression in the world, that's not going to come back. And that's one where the presence of weakness, in my mind, makes me think about doing something a lot bigger and thinking about where that weakness comes from, probably getting EMGs and probably doing a bigger decompression, because even with the best decompression, this might not come back. Does that make a difference for all of how you think about this, like a foraminotomy versus a full decompression in that he's got weakness?
Absolutely.
So I think it really does come down to the fact of, you want to do the least. And in terms of how big you go, whether you decompress them alone, whether you expand them to have a more robust fusion, I think it really depends upon how well you think you can decompress them. I mean, if you have to decompress them pretty wide, you make them more unstable, then I think you have to do more to fuse them. I think that's the point of the whole case. It's not that straightforward.
And then the other is if you start using advanced imaging and technologies, for instance, let's say you use OR and Stealth. Instead of if you don't use that technology, you're probably going to put 6 5-millimeter screws in, 4.5. But with that newer technology, you can put a larger diameter screw and a longer length screw. And as we know from pull-out studies that Martin Craig did 30 years ago, it does matter. Length is not as big as diameter, but you can start doing things and using HA coating on your screws. And my biggest concern with this gentleman is the fact that he has quadriceps weakness, tibialis weakness. It is progressive, and he's got severe stenosis, at least at those 2 levels. So my thought was probably addressing 4.5, decompressing and fusing, and then probably the 1.2, and not addressing 2.3 and 3.4, which are, he's probably had that. If we got an MRI on this gentleman when he was 85, it probably looked very similar to when he's 90. So I was just trying to address the fact that he had progressive motor deficit. If he came in only with neurogenic claudication symptoms, I would have a very different conversation with him. Like, sir, you're 90 years old. Start playing some more card games.
Real quickly, does anybody have an issue with 1.2's modic changes and any indication that is a sign of instability?
The one thing I would say is he has no facet diastasis. He doesn't have synovitis of his facet joints. So I could decompress it. I would feel comfortable decompressing that without fusing that one, personally.
I would get a myelogram and CAT scan before I did anything. I haven't seen a frontal or coronal view. But where you think that there might be stenosis at 2.3 or 3.4, I think getting a myelogram and CAT scan could easily tell you a little bit more about the facet hypertrophy and the neuroforamen and the degree of stenosis at 2.3 and 3.4. And if that looked fairly normal, then I'd confine everything just to L4-5. I think you can get a lot more information and plan a little bit better just taking the time to get a myelogram and CAT scan.
Did you say you had weakness in the quad?
Quad on one side and bilateral tibant.
Well, that's why you need the myelogram and CAT scan to see whether it's the 4 root or the 3 root or the 2 root. And I think MRI scans are great, but they can also give you information that could mislead you.
It's a good question, because if you look at 3-4 right there on the right-hand side, foraminally on the right, he's tight. And could that be his quads?
If this discussion has turned more towards addressing L1-2 and L4-5, which I agree, I think we have to mention, even if only to condemn it, the possibility of coflex. If you're going to decompress those 2 levels along individually, that can provide you some increased posterior height. We all
Yeah.
talk about it for a second.
There's no doubt that some guys, particularly in California, may be putting some X stops in here if it was a couple years ago.
Anyone consider or practice using cortical screws if they're worried about bone quality there?
It's a great concept, because you're
Almost
going
my
through,
entire practice is cortical screws, and I would absolutely do that because the guy's 90 years old and you're preserving his paraspinous musculature by not crossing over the facet joint, for sure. But I would do a complete facetectomy on him, and so I know that he needs instrumentation because he had that foraminal stenosis, and I think taking off half of the lamina, the bottom half of the lamina, and the entire facet joint works great with a cortical screw construct, and it's an 1.5-inch incision, and I could probably get it done in 1 hour and 45 minutes. In the past, I'd probably just do a lammy on him.
Yeah, I don't see what you lose with instrumentation here. I don't know why you would try to not instrument. It would be, if you decided you need a fuse, I would definitely do that. I think cortical screws are a great option.
it is.
I've used it in osteoporotic patients. You don't have ample time to try to increase bone quality. I actually use it more in tumor than I'd use it for anything. But I use trancortical screws almost exclusively in my posterior lumbars.
Fenestrate screws with method.
And so I'll jump on the non-union side. Let's say that you put screws in him and he's 93 years old now. And now instead of having a stiff, probably functional non-union at 4-5 with an in situ, now he's got screws that are haloed. And so now he's a 93-year-old getting a revision. I mean, there's every way you go you can get burned on this.
Absolutely.
My opinion on that is if it takes you an extra 15 to 20 minutes to put some interbodies in, you're not going to have that. I think the only worry with that guy, if you fuse him and you can get it done quickly enough, is 5-1 breaking down because there's a tall disc. Because 1 through 4 aren't going to break down.
And right, that's the other argument, right? So if you take down his midline structures, I mean, look at Sears data. Sears data says that if you do a decompression adjacent to a fusion, that you're more likely to fail and have a revision. So.
And I think most of the MIS surgeons in the room would not take down midline structures in this guy. I certainly wouldn't. I would decompress him. I would probably do a facetectomy at 4-5 to do an interbody implant, but his spinous processes, his interspinous ligament complex, that would all stay intact.
Right, but we just talked about maybe looking at his 3 root because of his quad, so
and then
maybe you would.
Well, no, then I would go lateral to medial on that. I'm a big proponent of lateral to medial decompressions, particularly if it's, again, the lateral 50% of the foramen. So what's interesting about this case is I've heard about 15 different opinions. Nice. So it's the standard degenerative deformity or spondylosis, not deformity, excuse me, but just a high-grade spondylitic spine with stenosis in a the elderly population. We don't really have good answers, and I think it comes to surgeon preference and what's best in our hands. It really is. So we don't get further behind. We're going to end this. Thank you, panel. It was great. Thanks for the session. Next.